the white matter, you compare, the white matter is dark is compared to T1 wetted image in which white matter is white. So these are the T1 and T2 wetted image to assess the difference. Fluid is black, fluid is white. This is the white matter. This is the white matter. In T2 it is a dark, in T1 it is a white. Gray matter along the cortex is the gray. Here is also gray. It is also gray. And the subcutaneous fat is white. Here is also white. But this is more bright than the T2 wetted image. Then the fluid attenuated inversion recovery FLAIR. This is basically a T2 wetted image in which we cancel the signals from the simple water, CSF. Water is black, white matter is dark, gray matter is gray, and the subcutaneous fat is white. So this is basically a T2, but in this we cancel the signals from the water or a simple fluid in the body. So it is useful in showing certain lesion in the brain and the spinal cord, especially in the periventricular region, because when we nullify the signals from the CSF, the adjacent signals, the adjacent pathologies are more appreciated than the rest of the skin. So this is the FLAIR images. Fluid is black, subcutaneous fat is white, gray matter is dark, white matter is dark, and gray matter is gray. So this is basically a T2. This is the axial section, this is the coronal section. Then these are the, this is the FLAIR image and this is the T1. How we difference, because sometimes it got confusion, okay, this is FLAIR or a T1 wetted image. Fluid is black in both sequence, fat is bright in both sequence, but we have to see the gray and white matter. The gray matter is gray, here is also gray matter is gray, but white matter is white on T1 wetted image, but it is gray or a dark on the T2 wetted image. So this is the main difference to assess the difference between the FLAIR imaging and the T1 wetted images. This is the T2 and the FLAIR image. Fluid is white in the T2 wetted, but it is black on the FLAIR images. Subcutaneous fat is bright in both sequence. Gray matter is gray. You see, this is along the cortex is gray, and here in T2 wetted it is also gray. And there is a white matter is dark. Here is also white matter dark. In this, there is a only difference is the CSF, which is black on the FLAIR images. Then the which sequence define the best abnormality. The T1 wetted image, it show the subacute hemorrhage. Very good. Subacute hemorrhage, not acute hemorrhage. Fat containing structure, because it contains the fat appears very bright on the T1 and the anatomical depth. While in T2 wetted images, best pathology we see is the edema, demyelination, infarction, chronic hemorrhage. These are all best seen on the T2 wetted image. Then the FLAIR images, in which we see the edema, demyelination, infarction, especially in periventricular region, because we nullify the signals from the CSF in the FLAIR images. Then this is the diffusion wetted images. It is very important images for the stroke. Nowadays, this is in the stroke protocol, in which I cannot get the normal diffusion wetted image. The normal diffusion wetted image is there is only these images. No one, this is the abnormal, which is high on the DWI. So in the, we assess the diffusion, whether there is a diffusion restriction or not. For when there is a diffusion restriction, mean there is any infarction or an infection. But mainly it is infarction on the basis of the clinical. This is the ADC mapping, and DWI, this is the DWI image, and this is the ADC image, apparent diffusion coefficient, and this is the DWI image. We say when there is a true restriction, diffusion restriction, when any lesion or any abnormality which appears hyperintense, mean bright, hyperintense. We use the terminology hyperintense, hypointense, or isointense. Hyperintense means white signal, which appears white or hyperintense on DWI, and that signal is low or hypointense on the ADC. Mean there is a true diffusion restriction, and this is seen in the infarction, acute infarction, hyperacute infarction. So this is very important sequence in the stroke protocol. DWI imaging has a major role in the following clinical situation: early identification of the ischemic stroke, differentiation of acute from the chronic stroke, because chronic stroke didn't give the diffusion restriction. Differentiation of acute stroke from other stroke mimics. Sometimes there are certain pathologies which represent as a stroke, but on MRI sometimes we get confused and we do DWI, because in diffusion restriction seen in stroke, not other demyelination or certain other condition. Differentiation of epidermoid cyst from the arachnoid. The epidermoid cyst and the arachnoid cyst, these are the similar, almost similar on the conventional MRI, but the epidermoid cyst show diffusion restriction on the DWI ADC mapping. Mean epidermoid appears hyperintense on DWI and hypointense on the ADC mapping. Differentiation of abscess from the necrotic tumor. Sometimes the abscess which appear as a conventional MRI is a peripherally enhancing region, but sometimes when the tumors also show necrosis, so we get confused, okay, whether it is a necrotic tumor or abscess. So we go for the DWI images for the diffusion restriction. The abscess show diffusion restriction, while necrotic tumor didn't show any diffusion restriction. Mean abscess appear hyperintense on DWI and hypointense on ADC map. Differentiation of herpes encephalitis from the diffuse temporal gland cyst. The herpes encephalitis may also show the diffusion restriction because of the inflammation. Then the other sequence is the gradient echo or susceptibility weighted image. It is used to identify the calcific deposit and blood degradation product. Whenever we suspect the hemorrhagic tumor, hematoma in the brain, we do so this in the of the hematoma or a hemorrhage within the intracranial hemorrhage. Otherwise, we didn't do in susceptibility weighted or echo in any other situation. This is the FLAIR image. Sometimes we get confused with radiant echo images, and basically in FLAIR images, fluid is black, and this fluid is white. And otherwise, other signals are the almost same. The gray matter is dark, and gray matter is gray. White matter is a dark compared to the gray matter. So this is the FLAIR images. CSF is black, and this is the gradient echo, in which when we see on the conventional FLAIR images, we see there is a hyperintense signal in the posterior parietal, right posterior parietal region. But we cannot sure it is hematoma, it is an infarction, or it is a tumor. So when we go for the susceptibility gradient echo, it shows the dropout of the signal. When there is a dropout of signal mean it appears black on the gradient echo. Mean it is there is a hemorrhage in this part of the tumor or a lesion or a pathology. On the gradient echo, the hematoma shows dropout of signal. Dropout mean it appears black on the gradient echo if there is a hemorrhage within it. This is the T1 wetted image. This is T2 wetted image. CSF is black. T1, CSF is white. T2, this is also CSF is white, but there is overall gray appearance. And the lesion is hyperintense on the with popcorn appearance on the T1 with high, and this is also heterogeneously hyperintense on the T2 with some flow wide areas, but it should drop out of the signal in the gradient echo. So this is any lesion which is a hemorrhage within it. So basically this is the large cavernoma. Popcorn appearance on the T1 and T2 is a pathognomic feature of the cavernoma. This is the magnetic resonance angiography, mean MRA. It is used for evaluation of the vessel in the brain, especially the carotid arteries and their branches. This is overall circle of Willis. In this, we cannot give any IV contrast. There is a physics behind that sequence. The vessels appears bright. The vessel with flow appear as a bright linear structure. Whenever there is a pathology or a filling defect or a thrombus, it appears low on the it appears black on these sequence this image. So this is basically the posterior circulation basilar artery, which divided into the posterior cerebral artery, and these are the internal carotid artery, which divided into the anterior cerebral, and this is the middle cerebral artery. So this is the MRA sequence. And now the MRV sequence to evaluate the vein without visible overlying structure. We cannot see any structure overlying it. We just only see the veins or a dural sinuses. It requires the IV contrast to enhance the visibility of the vein. In MRA, we don't give any contrast, but in MR, we give the IV contrast. In this, these are the internal jugular veins, and which extend these are the sigmoid vein, transverse sinus, straight sinus, and this is the superior sagittal sinus, and this is the confluence of the dural sinuses This is the magnetic resonance spectroscopy, MR spectroscopy. It is a non-invasive imaging of the brain that measures the relative level of various tissue metabolites. Whenever there is any lesion in the brain, it causes the damage. Or the lesion itself have if there is a tumor, it have a particular metabolites because of the rapid turnover of the cells in the malignancy. They gives variable metabolites, and when we measure these metabolites, we can characterize the lesion as a malignant, as an infective, as an infarction, as a inflammation. So this is the special sequence, MR spectroscopy. This is the normal in which Na is very high, because this is the metabolite of the neuron. This is when we measure the MRS in the neuron, this is the normal spectrum. Choline, creatinine, and Na, and we measure these ratios. This comes automatically in the software. MRS is very important in malignancy, demyelination, pyogenic assay, or neurodegenerative disorder. We measure these metabolites, ratios, in which the increased choline creatinine ratio, myoinositol and Na ratio, choline and Na ratio, these are increased, but there is a decrease Na and creatinine ratio. Plus minus in some cases, there may be lipid or lactic because of the necrosis. Slightly in the demyelination, there's a slightly increase in choline creatinine ratio, choline Na ratio, normal myo Na ratio, plus minus lipid or acid depending on the necrosis or anaerobic respiration. Decrease in the pyogenic abscess, there is a decrease in a creatinine, but increase acetate, succinate, amino acid, and the lactate. Lactate is a very important factor because in the pyogenic abscess. In neurodegenerative, there is a decrease in a creatinine because there is a damage of the neuronal cells. So Na is decreased, decrease Na choline, and increase myo-Na-choline. So these are the certain factors. These ratios are calculated automatically in the software, and then we correlate with these with in which condition it is mixed. What are the main indication? Indication, the first is the evolution and confirmation of a stroke. Because when a patient comes with hemiparalysis or a hemiplegia or a stroke, right-sided or a left-sided stroke, the first investigation in these cases is the CT, plain CT, to rule out the hemorrhage. Because if there is a hemorrhage, the MR can get mislead, and it is not exact. In acute cases or hyperacute cases, the MR has a very little role. So we have to give the treatment to the patient, streptokinase or something else. So we have to rule out the hemorrhage. So first investigation in a stroke patient is always plain CT. If there is no any hemorrhage but CT normal and clinically patient has a stroke, next investigation is the MRI with the stroke protocol. Mean it should include a DWI and ADC. The other is the assessment of the intracranial tumor and the vascular malformation. Demyelinating disease like multiple sclerosis, acute disseminated encephalitis, and then if the patient has a chronic headache, seizure disorder, mesial temporal sclerosis, dysmyelinating disorders in the newborn, in the children's, congenital brain malformation, evolution of the dementia like Alzheimer's disease, evolution of the infection, cerebritis, encephalitis, meningitis, tuberculoma, and brain abscess. In these cases, the MR is a very good resolution. But if MR is not available, then we should go to the CT. Or if there is a contraindication for the MRI, then we go for the CT scan. What are the advantages? Main advantage, it is a non-ionizing radiation. It can be used in the pregnant female or during lactation. It is a non-invasive. It is painless. Patient is just to lie down. Excellent soft tissue imaging with high contrast. Very good contrast as compared to CT or other imaging modalities. Then there are the axial, sagittal, and coronal and oblique images can be obtained without repositioning of the patient. Patient lie in the supine, but we can take these views in the same position. No bony artifact. This is especially when we on the CT, the petrous part of the temporal bone or a petrous apex causes the artifacts over the posterior fossa. Sometimes we cannot interpret pathology properly on the pathology of the posterior fossa properly on the CT. So in these cases, MR is the investigation of choice. Disadvantages: it is very expensive, and it is available in large setup only because it needs trained staff. Not every setup it is available. There may be claustrophobia because the patient has to lie down in a tunnel or a small tunnel, and there is a ringing bell of the magnetic because it uses the magnet. So ringing bell of the magnet sometimes hears in the hears by the ear, so the patient can feel fear. So this is also one of the disadvantages. And there is a long scanning time because when we do the MRI, the minimum 20 to 25 minutes can take per patient. So the patient has to lie still, no any movement, shallow respiration. Sometimes it can also make difficult to the to do the MRI, especially if the patient has a on the ventilator, or they cannot undergo to the MRI room because of the cylinders or because of the instrumentation. We cannot go these into the MRI, which has a very high magnetic force. And because of the long scanning time, there may be the movement artifact. What are the contraindication? Metallic implant. Any metallic implant in the body is a contraindicated, like aneurysmal clips, like prosthetic heart walls, some prosthetic heart wall, like pacemaker, like a cochlear implant in the ear. These are the main contraindication because of the magnetic. When we put the metal in the magnetic field, these can attach to the field or a machine, and the machine can get burst. So it is very dangerous for the patient. So we have to rule out first, is there any metal in the body? And then we put the patient in the MR machine. Claustrophobia is a relative contraindication because some of the patient cannot lie down in a tunnel and they refuse for the MRI. And then there's a normal anatomy of brain on an MRI. When we start the MRI brain, it starts from the base of the skull up to the vertex normally. So this is the base of the skull, this is the medulla, and these are the cerebellum. And this is the fourth ventricle, and in front of the medulla, there is a prepontine cistern in which there is a basilar artery. These are the mastoid air cell. Air always appears black in MRI, in either whether it is present in the mastoid air cell, whether it is present in the sinuses. Then this is somewhat higher. We are going higher up. This is the medulla, cerebellum. This is the fourth ventricle between the medulla and cerebellum, basilar artery. And here comes the temporal lobe. And these are the sphenoid sinus, ethmoid air cells. Then again we go up. This is the globe, and this is the optic nerve. And these are the external oblique muscles. These are the recti muscles, ethmoid air cells, temporal lobe, and this is the cavernous sinus in which there is a carotid artery. This is the internal carotid artery. In a plain MRI, the vessels always appears black because of the physics behind it. And this is the fourth ventricle. This is the pons because it is now bulged, and this is the medulla. But pons is a protrudent structure, and this is the cerebellum. Butterfly shape is the midbrain. Behind this is the cerebellum, and this is the frontal lobe, temporal lobe, and this is the Sylvian fissure. Basically, this is Sylvian fissure. When the Sylvian fissure comes, the parietal lobe appears. So this is the parietal lobe, and this is midbrain. In this diamond structure, white structure is the supracellular cistern. Adjacent to this is the middle cerebral artery, and this is the anterior cerebral artery. And there is a division of the internal carotid arteries. And behind is the posterior lobe, which is very small lobe in the brain. This part is only occipital lobe. This is the midbrain, and this is in the midbrain posteriorly, this is the aqueduct, white structure, because aqueduct contains the CSF, so it appears white. And these are the folia of the cerebellum, and in the around the midbrain there are the posterior cerebral artery. This is the Sylvian fissure, so the parietal lobes come. This is higher up level frontal lobe, and this is the third ventricle. Adjacent to third ventricle, these are the thalami, and these are the frontal horns, which very little bit appear. When we see the frontal horns, we see the basal ganglia. This is the quadrate nucleus, and this is the lentiform nucleus. And this is the parietal lobe, and this is main structure. Actually, this is the Sylvian fissure. Anterior to Sylvian fissure, the cortex is known as insular cortex, and it is very important for the because in infarction, this is the first cortex to be involved. So this is very important cortex. Now these are the frontal horns, and these are the trigone, in which this black shadow is because of the choroid plexus. When we see the frontal horn, just beneath the frontal horn, the quadrate nucleus, this is the quadrate nucleus, and then there is a lentiform nucleus. The lentiform nucleus consists of two parts, putamen and globus pallidus. Putamen is the lateral part and globus pallidus is the medial part, and this is the thalamus. This is third ventricle. So when the internal capsule run between the anterior limb run between the thalami, this is between the quadrate nucleus and the lentiform nucleus, and the posterior limb between the lentiform nucleus and the thalami. So this is the normal location of the internal capsule. Higher up level, these are the frontal lobe, this is the parietal lobe, and there is the interhemispheric fissure, and anteriorly is the genu of the corpus callosum, posteriorly is the body of the splenium of the corpus callosum. And these are the body of the lateral ventricles. This is the white matter, and this white matter, I mean the white matter at the level of the body of the lateral ventricle, and below it is known as corona radiata, or a deep white matter, and the cortex is this gray-white line. When we don't see any ventricle, the white matter is known as centrum semi-ovale. So whenever you see any report in which the pathology is described in the centrum semi-ovale, mean it is above the lateral ventricle. And this is the interhemispheric fissure, frontal lobe, parietal lobe. The elevation is the gyrus, the depression is the sulci. Now this is the sagittal images. We go from the parasagittal to sagittal image. This is the anteriorly is the frontal lobe, inferiorly is the temporal, this is parietal lobe, and posteriorly is the occipital lobe. All four lobes are seen. This is the white matter, and this gray line is the gray matter. And this is the cerebellum, posterior fossa. This is another view. We show the frontal lobe, parietal lobe, occipital lobe, cerebellum. This is the orbiter globe, and there is a transverse sinuses. This is the mid-sagittal plane in which we see the corpus callosum. The corpus callosum is in the middle of the brain. This is the frontal lobe, parietal lobe, and this is cerebellum. And this is also midbrain, pons, and medulla. And then this is the pituitary fossa we see best on the sagittal view, and this is the clavus, spinal process, and this is the cord. And this is the corpus callosum. Anteriorly is the genu, posteriorly is the splenium, and this is the body. And here, inside there is a rostrum of the corpus callosum, which is the first part of the corpus callosum. This is the coronal images of the brain, and this is T2-weighted image. We are coming from behind to anteriorly, and this is the body marker is given. So we are at this level. So this is the cerebellum, sigmoid sinuses, and this is the anti-hemispheric fissure, superior sagittal sinus. And these are the parietal lobes posteriorly. When we come anteriorly, this is the falx cerebri, this is the lateral ventricle, this is the cerebellum, and superiorly is the vermis, inferiorly is the tonsils, which we see when there is a tonsillar herniation. And this is a tentorium cerebelli, which separate the supratentorial and infratentorial structures. This is further anterior view. This is the lateral sulcus or the Sylvan fissure, and this is the temporal lobe, medulla, pons, midbrain, and these are the Because of this is the insula, the cortex anterior to this is the insular cortex or insula. This is further anteriorly genu of the corpus callosum, and there is a caudate nucleus between the frontal horns. Then there is a lentiform nucleus which consists of the caudate and the putamen. And this is the Sylvan fissure, and these are the optic nerves. This is further anteriorly anti-hemispheric fissure, superior oblique fissure, sinuses. This is the genu of the corpus callosum. Lateral sulcus are below which is the cerebellum, below which is the temporal lobe. So what is corpus callosum? It is a large C-shaped nerve fiber bundle found beneath the cerebral cortex. It is stretched across the midline of the brain and connecting the both cerebral hemispheres. So information go from here to there, and there is the four radiological part of the corpus callosum: rostrum, genu, body, and spleen. Stomach is not separately we can label, but rostrum, genu, body, and spleen. Internal capsule. It is a white metal structure situated in the each cerebral hemisphere of the brain. It separates the caudate nucleus and the thalamus from the putamen and globus pallidus. Putamen is the lateral and globus pallidus is a medial part. So this is the MRI brain axial section T2-ated image that show this is the caudate nucleus, and this is the lentiform nucleus, and this is the posterior limb. So this is the internal capsule. Now we go for the revision. There is some quiz type. So you can write down your answer in the chat box. Just wait, I suppose. Still lecture is going on. I will give the answer in the end.
Madam, chat box on ही है. अभी तक कोई question नहीं है.
ठीक है, thank you. So when a patient with a stroke comes in the ER, which is the investigation of the choice? You can write your answer in the chat box. Plain CT, not a contrast CT. Plain CT is the right answer, because sometimes you may get confused, but the first investigation is the plain CT or a non-contrast CT. So this is the CT of the patient with came with a stroke, and CT was normal. So the next investigation is the which one? Yes, ADC, MRI with DWI and ADC, stroke protocol. This is the MRI, DWI of the same patient, and the CT was normal, but when he go for the MR, because patient is clinically the neurological deficit, so the patient underwent the MRI. I only show the DWI images in which there is a diffusion resection. This posterior left posterior parietal region is bright on the DWI. So there is an infarction which was not initially picked on the CT. We do CT first because it is every in the emergency setup it is available, and we sometimes we don't know the history of the patient. There may be any implant, a metallic implant in the body, and we have to rule out the hemorrhage. So if the patient came with the memory problems, what will be the investigation of choice? Anyone? Investigation of choice is the MRI brain. MRI brain, we never do in only T2. This is only for the screening purpose. Sometime in some setup it is used. This is the MRI brain. We have to do the T1, T2 and FLAIR images in plain MRI. If we ask someone to plain MRI, it is T1, T2 and FLAIR. When we say stroke protocol, T1, T2, FLAIR and DWI ADC. If we say the contrast MRI, T1, T2, FLAIR, and the post-contrast images. Post-contrast MRI is recommended whenever there is a infection, inflammation, or a tumor, or a demyelinating diseases. If patient has any contraindication for the MRI, like he has a stent, cochlear implant, or he has a pacemaker, then investigation is in a patient with a memory loss is the CT. First, the first investigation is the MRI. If the patient came with the head trauma in the ER, what will be the investigation? CT. CT is plain CT, non-contrast CT, because it is the most useful investigation. Everywhere it is available, and particularly useful for hemorrhage and the fracture, because fracture we are easily seen on the CT rather than on the MRI. And hemorrhages, or obviously acute hemorrhages, are very good seen on the CT as a hyperdense. So these are the certain cases of the CT. In the CT, the bone clearly. In MR, you can't see the bone clearly. This is very different, good differentiating point. So this is the CT. We show there is a epidural hematoma and there is a fracture of the fracture. This is the same patient and this is the separate patient. And there is also contusion in the brain parenchyma. And here there is a subdural hematoma. Patient with a history of headache. He had a history of intervention of the right middle cerebral artery aneurysm. Investigation of a choice. He had intervention. Intervention was done. Now he came for the headache. What is the investigation of choice? CT. Why? Because there is an intervention for the right middle cerebral artery aneurysm, and if there is an aneurysmal clip, it is contraindicated for the MRI. So we have to first rule out the aneurysm, how aneurysm was operated or intervention done. So the first investigation is the CT. This is the reason behind it. So now sequences, fluid is black, fluid is white. White matter is white, gray matter is dark. Which one? First sequence is T1, this is T2 weighted images. Very good. Sequences. The fluid is black, fluid is white. White matter is dark, white matter is dark. So which sequences? FLAIR and T2 weighted images. Again, there's a fluid is black, fluid is white. There is also fluid is black. Gray matter gray, gray matter gray, gray matter gray. White matter is dark, dark, dark. So which sequences? This is FLAIR, T2, and this is also FLAIR. So thank you. If any query, there was just one question. Okay, for the neurovascular compression, like trigeminal neuralgia, yeah, any neurovascular compression, we go for the MRI. And we say MRI, it's mean the plane study mean T1, T2, and FLAIR. But when we have to assess the neurovascular structures, because of any nerve compression by tumor, by infection, or something else, we have to go for the contrast study. It depends on the underlying clinical query. For neurovascular, especially for the vascular, we go for the contrast study, because if there is a trigeminal schwannoma or a neurofibroma or something else, and it compressing any adjacent vessel, how we can see the vessels without contrast? So it is mandatory to give the contrast in these cases. Any other query? No. Basically, this is my fault. I don't. Initially, it's for CT. When we do the CT or we do the reporting of the CT, we use the word hypodense, hyperdense, isodense. Okay. Dense word is used for the CT. Intense, hyperintense, isointense, hypointense. These are the words for the MRI. Both are bright structure, but hyperdense is used for the bright structure we see in the CT. Hyperintense, we use the word when we see white structure in the MRI. So hyperintense is used for the MRI, while hyperdense is used in the CT. Meaning is same, structure is the same, but these are the basically words for the separate modalities. Any other query? Okay, thanks so much.
मैडम ऐड करें मैडम?
हाँ बस
ओके मैडम, टेक केयर, अल्लाह हाफिज।
अल्लाह हाफिज।